Our next speaker is going to be Dr. Carter Wray. Dr. Wray is an assistant professor in pediatrics as well as neurology in the Division of Pediatric Neurology at OHSU in Dornbecker. He is a member of the Comprehensive Epilepsy Center and the director of the Kinetic Diet Program. He is also the local vice chair of the Epilepsy Foundation Northwest Oregon section. Dr. Wray completed undergraduate training at Dartmouth College and earned his MD degree in the Medical College of Georgia. He completed pediatric and pediatric neurology residency training in the University of Colorado, and then his residency in the pediatric clinical electrophysiology at the University of Washington in Seattle. Dr. Wray has research interests in the areas of surgical treatment of epilepsy and the genetic causes of epilepsy, and has authored a number of papers and in book chapters. He's also maintains a busy clinical practice and is also actively involved in academics and teaching. Let's welcome the doctor.
So thank you for having me here today. I'm going to be talking about something that I think, as Dr. Motika mentioned, is often under-addressed, and it's a problem that's been around for a long time. We're now calling it SUDEP, which most people mean sudden unexpected death. Some people say it's sudden unexplained death in epilepsy. I think that we'll talk a little bit about what is unexpected and what is unexplained. I think that, unfortunately, I don't have any financial conflicts, certainly not with regards to this topic. This has been around for a while. Actually, one of the more famous cases in history comes from George Washington, whose wife Martha had a child from her first marriage who had epilepsy, and I think that George Washington himself actually described her having SUDEP, and so I'll just read his words, that Patsy rose from dinner at about 4 o'clock in better health and spirits than she appeared to have been in for some time. Soon after, she was seized by one of her usual fits and expired in it in less than 2 minutes without uttering a word, a groan, or scarce a sigh. And I certainly think that this is sort of the most dreaded outcome of epilepsy, certainly for the parents of my patients, and I think also for adult patients as well, and their loved ones, that people can pass away, and sometimes we just don't know why, and certainly we often don't see it coming. I think the fact that Patsy had actually been better controlled with her seizures is very disconcerting to many people to think that my child or loved one can be doing better with their epilepsy and still just out of nowhere pass away. I certainly have had patients where they've been in the best seizure control of their lives and then SUDEP has happened. So it's certainly a very frightening thing, and I think that leads a lot of us to not feel comfortable talking about it all that often. So what is SUDEP actually? And again, some people use it as the unexpected, some use the term unexplained. It can be witnessed, as in the case of Patsy, or it could be unwitnessed, and certainly a lot of patients with epilepsy are found, particularly found in bed in the morning to have passed away in the night. It's not seizure death that's associated with a trauma like a car crash, because we certainly know that patients with epilepsy do pass away from things like that. And it's not drowning, which certainly water safety is, I think, the biggest issue for our young patients with epilepsy is water-associated death. There may be evidence that a seizure happened, there may not be, and then we want to make sure, ideally, if we think a patient has gone into a prolonged seizure and that seizure of status epilepticus is something that we couldn't control despite the medical interventions that we as physicians try and provide, that is to some extent a different problem. It's still unexpected and it's still very sad, but it's a slightly different phenomenon. To be definitively called SUDEP, we do include patients only who've had autopsies. There are certainly a large number of patients where we call it probable SUDEP, where it certainly looks like SUDEP, it acted like SUDEP, but for some reason the patient didn't have an autopsy. So we certainly discuss that and consider that SUDEP probably, but to be definitive, we really want to make sure there wasn't some other problem with a patient's body that could have caused them to pass away. So as I mentioned, I mean, George Washington described this phenomenon a long time ago, and the scientific literature certainly on SUDEP goes back quite a ways. And here's a paper from 1902 where somebody sort of said why epileptics may die suddenly at any time. And the first line is, I think, really what we're now calling SUDEP. As I mentioned, patients who go into prolonged seizures that we can't stop are patients who have refractory status epilepsy, because we know are at much greater risk of passing away than patients who have well-controlled epilepsy. Car crashes, drowning are certainly the accidental causes of death. And then patients with epilepsy, like all of us, will pass away of something. And so certainly patients with epilepsy may just die of normal causes of death. But I certainly think that the SUDEP is really the one that we've had the hardest time wrapping our minds around. Certainly death happens more often in patients with epilepsy than it does in patients who don't have epilepsy. Certainly the rates, depending on which study you look at, are much higher. Some studies showing 24 times as likely to die suddenly as patients who don't have epilepsy. In children, most children don't die suddenly, and as such, patients with epilepsy, certainly who are young, have a much, much higher rate of passing away suddenly than patients who don't have epilepsy. And it's a very large portion of patients who have epilepsy can pass away from SUDEP. The Sillanpää paper that I'm going to reference a couple of times is a Finnish study. The Finns have the benefits and curses of socialized medicine, but Sillanpää has access to medical data from the whole country and has been able to do really wonderful long-term study of what happens to Finnish people with epilepsy, because he has access to their records. And so for his group of patients who had onset of epilepsy in childhood, by the time 40 years later he looked at the data set, a third of the patients who had died of SUDEP. So incidence is how often something happens, particularly the risk in this case of somebody dying over a period of time. And so we need to look at this, and I'm going to use the 1,000-person year number just because that's what most papers reference. So if you think of 100 patients having epilepsy, all of them having epilepsy for 10 years, how many of those people would die because of SUDEP? And usually, as Sillanpää's paper showed, it was about a third of patients who passed away was SUDEP. Some papers have showed slightly higher rates. Some papers have shown slightly lower rates. This is a fairly rare phenomenon. These groups, the Ficker, Walczak, Tennyson, Litzmup, are looking at huge populations. So populations of patients like, we'll talk about the Camfield group. They looked at all of the patients in Nova Scotia. They also have socialized medicine, and similar to the Finnish. The Mayo group has very good records for everybody who lives in Olmsted County, Minnesota, because everybody who lives in Olmsted County, Minnesota goes to Mayo because Mayo's in Olmsted County. But nonetheless, so you're talking about around 1, maybe 2 or 3 in some of the more common, in the more worrisome papers. Certain patient populations, though, are going to have a higher incidence, or more of them are going to pass away over that same sort of theoretical 10 years that all 100 of them had epilepsy. And particularly patients who had bad enough epilepsy to need to get epilepsy surgery that Dr. Spencer talked about. But if that surgery had not actually stopped their seizures, and so these are patients who have really refractory epilepsy, at least 5 times as higher rate of those patients passing away from SUDEP. So failed epilepsy surgery patients was one cohort that had very high risk. The vagus nerve stimulator is an electrical device that gets implanted under the skin, typically under the clavicle, and again is something that is being used in patients whose seizures are much harder to control. They're not the 2/3 that Dr. Spencer showed us where they stopped with a drug or 2. These are patients who needed something above and beyond those drugs. They may not have been focal surgery candidates to take out a part of their brain. And so at least twice, if not 3 times, as high a rate of SUDEP as the sort of bigger population with epilepsy. Slightly more of those patients actually did pass away if the vagus nerve stimulator was not turned on, because some patients either decide that it doesn't help them, or it's something where they're having some side effects, and so turning the device off. Or also in the original studies, we had some patients who had the device in, just like with the NeuroPace, where it wasn't turned on yet, and looking at the SUDEP rates in that first few months of the sort of sham period, slightly higher rates. There's a publication of patients who'd had deep brain stimulation put in. That's wires actually going deep into the brain, into the thalamus, which is one of the central relays that involves spread of seizures to different parts of the brain. And so that's something that's more often used to treat movement disorders like Parkinson's disease, but there has been a trial to see if that might help patients with epilepsy. And they had also, like all the other surgical cases, more SUDEP because these are probably more refractory patients. I obviously care a lot about childhood onset epilepsy, and fortunately SUDEP is rarer in children. The one paper that shows the highest rate here is the Sillenpaw paper, and that, as I said, is a 50-year follow-up. So he had data on patients who had onset of epilepsy 50 years ago, and those people who were then children and are now obviously much older had a much higher rate of SUDEP compared to patients who had adult onset epilepsy. But the other groups, like I said, the Canadians, the Dutch, all had fairly low rates of SUDEP during the pediatric years. So when does this happen? Certainly, the longer you have epilepsy, the more chance there is for SUDEP to occur. And so certainly people who've had childhood onset epilepsy have a longer life with epilepsy. And yet most of the SUDEP that does happen tends to happen in people once they've reached adulthood. So the Sillenpaw paper had no patients under 14 years of age with SUDEP. Over that 50-year time period, the average was that they did pass away at around 26 years old. The Canadian group, which basically has all of the patients in the province of Nova Scotia, said that they had never had SUDEP under the age of 21. The Donner paper is slightly different in that they started actually by looking at autopsy records, and they did find patients as young as 8 months. I personally have had a patient who was 5 years of age who passed away of SUDEP. So it certainly does happen to young children, but it seems to be pretty darn rare. The Kallenbach paper is all of the a large Dutch cohort, and the Walzak paper was just sort of an all-comers, and they did not see it in children either. I certainly think that we know it happens, but we certainly know that it happens less often. As I mentioned, the longer you have the epilepsy, the more chance that SUDEP can happen, and so certainly one of the risk factors is epilepsy that starts early on. Certainly the very bad infantile epilepsies that start when babies aren't even a year of age seem to be at a very high risk. Patients who've had epilepsy for over 30 years, that's similar to what I was mentioning with the Finnish paper, where they saw that around 26 they seemed to have the highest rate of patients passing away. The worse the epilepsy is, insofar as how frequent the seizures were, more frequent seizure patients seem to be more at risk for this happening. Particularly convulsive seizures, or tonic, stiffening, and clonic rhythmic jerking seizures are a particular risk factor, and we'll talk about that particular seizure type in a little bit. And patients who had to be on more anti-epileptic medications are at risk. And it's hard to say, is it that they're on more medications, or is it just that the fact that they have worse epilepsy requires them to be on more medicines to try and treat their bad epilepsy? And I certainly think most of us feel that the predominance of problem is with the patients who have difficult to control epilepsy. And the drugs are just our attempts to try and help ameliorate that epilepsy. It certainly seems that if you are supposed to be on a lot of drugs but don't take them regularly, that increases the chance of SUDEP happening. I think that some of this is from autopsy data, where they've looked at blood levels of the anti-epileptic drugs in the bodies of the patients who passed away, and many of them have lower blood levels than they had when their seizures were better controlled. And certainly I think that compliance is just a very difficult thing, staying on the medicine. Which is certainly why we're encouraged, as Dr. Spencer mentioned, that some of the new drugs are going to be once-a-day dosing, because that really helps patients take them if they don't have to remember to take them 2 times a day, or for some of our liquid medicines, even 3 times a day, which is quite unfortunate. Patients who had cognitive disability were more at risk for SUDEP. I think that cognitive problems and developmental disabilities are common in patients who have brain problems, and epilepsy is one manifestation of the brain problems, but certainly the patients that I take care of who have cognitive problems as well as epilepsy have more a brain problem than our patients who just have seizures as their only manifestation of their disease. It's possible that stress can be associated with patients passing away. Certainly we know from the heart attack literature, which has a lot more patients who pass away, that major emotional life changes like divorce, losing your job are associated with post-stress mortality, and it seems like that may be happening with SUDEP as well, although we have so many fewer numbers than the heart attack literature, so it's really hard to say for sure. Many papers say that there is a male preponderance of SUDEP. It's not a huge difference, about 60% in the papers that found that there's more males passing away from SUDEP than women. Patients who have a physical abnormality of their brain, as Dr. Spencer's patient who had the cortical dysplasia, that's what we would consider a structural lesion where part of the brain physically isn't normal. Either it didn't grow right because of something like a cortical dysplasia, or somebody who's had a stroke that leads to their epilepsy. Those are structural or physical problems with the brain that make them more at risk for passing away. Neuroleptics are sometimes called antipsychotics. These are medications like Abilify, Geodon, Haldol, all of those medicines, Seroquel, seem to have associated with them risks for heart electricity abnormalities, and for some reason that seemed to be more common in women. The post-ictal or after-seizure EEG suppression, the EEG is what Dr. Spencer was showing you, the brainwave electricity tracing. So I'm going to show you just two of those. After a seizure, the brain does different things, and certainly for those of you who've seen seizures happen or seen your loved ones have seizures, after the seizures, very frequently they're sleepy, sometimes have headaches, sometimes they have one part of their body that doesn't work right, or what we call a post-ictal weakness, and so all of these are common post-seizure problems. If we actually look at the brain electricity during a seizure, here are two patients who have the seizure happening as this sort of rhythmic discharge that's happening here. After this patient's seizure, the brain electricity is actually quite flat. This super squiggly stuff is actually probably just muscle artifact, and so it's the muscles in the patient's body, but their brain is really not doing much of anything. This seizure down here has, again, the seizure is happening, this sort of rhythmic discharge going on, and then here's where the seizure ends, and immediately afterwards the seizure is gone, but the brain activity is, there's up and down. There is brain electrical activity. It's what we call slow activity. We sometimes refer to as slow as brain dysfunction. The brain's just not working right. But this slow activity is activity, which is good, and it's something that happens as the brain's trying to sort of reorganize itself and get back to functioning. And so I think of the slow activity after a seizure as being the electrical corollary of that sleepiness, headachy, not feeling quite right that many of you have seen in your loved ones. And so I think that this bottom is much more common, that after a seizure, patients go straight into slow activity. This is sort of the comparator from a paper that described some patients who had seizures and then immediately afterwards had flattening or lack of brain activity were more likely to die. So what this group had done is looked at patients who had been through their epilepsy monitoring unit and later had gone on to have SUDEP. And was there something different about their EEGs compared to their patients who had gone through their monitoring unit and hadn't passed away from SUDEP? And what is really going on here, and there is a time break here because this patient actually really didn't have resumption of brain activity for 140 seconds, so over 2 minutes of really no brain electrical activity going on. And to me, this is another marker of a more severe seizure, a more severe epilepsy. This brain, while it is not working, may not be able to do the normal things the brain is supposed to trigger your body to do. Most importantly, breathe and have your heart beat. And so there's certainly big issues of breathing and blood supply that are going to be things we're going to talk about as sort of mechanisms of SUDEP. But I certainly think that this after seizure flat EEG is something that worries us as epilepsy doctors when we look at the tracings of our patients who are in the epilepsy monitoring unit. We're actually seeing the electricity not only during the seizure, but afterwards. So characteristics of patients who had SUDEP who did pass away in childhood. So this is based on the paper that I mentioned started with autopsy records. So obviously it's focusing in on patients just who died, not looking at other children with epilepsy. There were 27 patients that they found that were children between 8 months and 15 years of age who passed away of SUDEP. There's another one of the studies where there was a slight boy preponderance or male predominance. The epilepsy type that was most common in these patients was epilepsy that was symptomatic, and that means the seizures are a symptom of some underlying brain problem. So either a structural problem, like we mentioned, with the brain not growing right, or a stroke, or a patient who had hypoxic injury if the baby didn't get delivered in as healthy a way as we would like, or patients who have a disease like a metabolic condition that would cause them to have seizures as a part of that metabolic condition or brain dysfunction. Those patients were much, much, much more likely to pass away from SUDEP than Cryptogenic is not a term I like to use very much. Both of these bottom two groups of epilepsy are patients where we don't know why they have epilepsy, and really that's the majority of patients we have with epilepsy. We don't know why they have their seizures. We can make a statement where we think it might be genetic, but certainly in at least 3/4 of patients with epilepsy, we don't know why it's there. And so I think that the data showing that more patients who passed away had symptomatic epilepsy is certainly something that harkens back to this idea that worse epilepsy is more likely to result in SUDEP. All of the patients who passed away from SUDEP in this autopsy case series had generalized tonic-clonic seizures, so these were not patients who just had focal seizures. They had seizures that spread to the whole brain and caused their whole body to convulse. And again, I think that gets to the severity of their seizure type. A large chunk of these patients were only on a single seizure medicine, so probably kids who seemed on some levels, as I said earlier, sometimes they seem better controlled than other points in their lives. A good chunk of the patients, though, were the refractory patients who were on multiple anti-epileptics, but unfortunately 1/3 of them did not have as much seizure medicine in their bloodstream as we would have liked to be able to keep their seizures under better control. So compliance definitely is a big issue, and some people say the biggest treatable or intervenable issue for SUDEP. About 2/3 of these patients were found in bed, and that's certainly not only the case for pediatric SUDEP, but certainly for adult SUDEP as well, as a lot of these seizures happen at night. 10 of them were witnessed, so their loved one actually saw, similar to what George Washington did, witnessed the event which involved their child passing away. 5 of them lost consciousness and had their heart stop beating after the seizure. 5 of them lost consciousness, didn't have a seizure, but their heart just stopped beating. And so I certainly think that on some levels is the big dread, is that the seizures are under control, and yet this can happen anyways. And I certainly think the one patient drowning in a bathtub was actually still considered SUDEP because the autopsy showed that there was not actually water in the child's lungs. So it wasn't that this child had a seizure and drowned. This child actually had something different go on with their heart and lungs that caused the child to die in a bathtub, but not because of the normal concern we have of children drowning in tubs. There's another paper that talked about witnessed SUDEP, and most of them were having convulsive seizures, as I mentioned, the whole body going on. One of them had a sort of classic aura of just feeling that the seizure was going on, didn't actually have the seizure, but just that same sensation, which many of us as epilepsy physicians think is actually it's part of the seizure. The aura is really just a small part of the brain being involved, while the rest of the brain is awake enough to know that they're having that feeling, they're smelling that smell, they're seeing that weird thing that lets them know the big thing is coming on later. And so even just that small part of the seizure in this one patient was probably enough for him to know that it was coming on, and then he passed away. Half of them got CPR immediately. We'll talk about CPR being helpful in some patients, because there certainly is what we call near-miss SUDEP, where patients look like they're going to die, may be dying, but get rescued. But half of these patients who did pass away had CPR immediately. Many of them, the remainder, had CPR initiated when the paramedics got there later, but obviously for this patient group, none of these 15 survived. 3 of them were stabilized and that their body was able to get a heartbeat back, and we were able to breathe for them, either the paramedics initially just using a bag or when they got to the hospital being put on a ventilator, before they eventually succumbed, either because their body continued to degrade as it had suffered too severe an injury, or sometimes the family elected to withdraw care. And I certainly was involved in a case like this here about 1.5 years ago, and I certainly think that was an incredibly emotionally difficult thing for a family, to have a child who was technically alive because her heartbeat had come back and we were able to breathe for her on a ventilator, but clearly she would never be the daughter they had had the day before that event. And I think that that's just an absolutely awful place to be emotionally. Certainly, I can't imagine being her parent, but certainly even just as a physician, it was just very, very difficult for all involved. The difficulty of breathing was certainly something that many of our patients, when they seize, don't breathe normally, but often it's more of a shallow breathing, whereas there seemed to be some more choking type respiratory pattern that was described by the people who witnessed these 15 cases of SUDEP. And again, lungs and heart are going to be 2 big issues that we're going to talk about. So why are these patients passing away? Certainly breathing and heartbeat are necessary to stay alive. The first three things, asphyxia or obstruction of the airway, so having something get over the patient's mouth or choke in such a way that they can't get the air to move in and out. The lungs are just not working spontaneously, too much fluid going into the lungs, or the heartbeat not being something that can send enough blood to the body to keep the body alive. So these are the sort of things we're going to talk about. We don't have great data because this is unexpected, and so it's something that we don't typically have. Looking at patients who did pass away of SUDEP, a lot of them have too much fluid in their lung. So we certainly know that during seizures, some patients will send fluid into their lungs that shouldn't be there. That certainly was very common between just a little over half and 70% of patients who had SUDEP. There could be too much fluid in the brain, and that can be something that causes the brain to stop working if there's too much swelling or cerebral edema inside the skull. Within the heart, there certainly are many patients who we know have heart rhythm changes, so the rhythm of their heart beating is not normal either during or after a seizure. There's also been evidence from autopsies that there's something physically different about some patients' hearts, and then also enzyme changes in the same way that we can detect a heart attack with enzymes that show that the heart muscle is dying. We've seen that in patients with SUDEP as well. So talking about the heart electricity instead of the brain electricity, the EKG is the German for cardiogram or heart tracing. And we certainly know that a lot of patients have fast heartbeats. Some patients have actually slow heartbeats either during or after a seizure, and if it's too slow, then you're not sending blood to the other parts of the body that need it. And some patients actually just stop having heartbeat altogether. I think that a lot of these other things are specific types of heart electricity changes that I'm not going to get into, but all kinds of crazy things can happen to the heart, and the heart is controlled by the brain, so certainly if the seizure is going on, it can be affecting the heart beating. As I mentioned, most patients who have seizures have fast heartbeat. 91% of this patient's study had heart going too fast. Certainly bradycardia or slow heartbeat happens in some patients, and then some patients can have complete what we call arrhythmia, or just heart stop beating altogether associated with their seizures. Usually when their heart slows down, their breathing slows down as well. And the question Dr. Nashef brought up in his paper is, can just slowing down of the heart rate and breathing reduction associated with that cause SUDEP? And I certainly think in some patients that probably is the case. Looking at heart traces, particularly in patients with temporal lobe epilepsy, because this is the most common kind of epilepsy in adult patients with seizures. Most of them, again, had heart rates getting fast. The heart rate seems to be greater in patients who are younger. The heart changes, however, could happen even before we could electrically see the seizure happening in the brain. So it certainly is something where we know that this can be going on even before we're able to detect that the seizure is happening. Sometimes it happens immediately at the beginning of the electrical seizure, and then some patients happen after the seizure is done that we then have the heart rate changes. During that seizure or ictal phase or post-ictal, we certainly can see after seizure heart abnormalities, and the longer the seizure is, and particularly if they're generalized convulsive seizures, there's more risk for the heart rate being abnormal. There's not a particular medicine that's associated with electrical changes in the heart. I think a lot of patients have been worried, or a lot of physicians have been worried about seizure medicines that affect sodium channels, because the sodium channels are certainly a very good target for controlling seizures. There are, however, sodium channels in the heart, and so some people's worry is that can you be slowing down the heart's electrical patterns by giving patients seizure drugs? And we certainly do check some patients for certain seizure drugs to see what their heart electricity is like. But in general, if you look at the SUDEP data, there's not a drug that is more dangerous than other drugs. As I said, slow heart rate during seizures certainly has been documented even in younger patients. He had a focal seizure that came out of his right temporal lobe, and 2 seconds after onset, his heart rate slowed down, and then he had 22 seconds where his heart did not beat at all. And I certainly think this is a sort of big fear for a lot of people, is that their heart could just stop working. Once this has been documented, many patients will actually have pacemakers put in, because even if we can't stop the seizures from causing the heart to stop beating, we can put in an electrical device that can at least trigger the heart to keep going, even if the brain is not telling it to. This patient interestingly, actually had tonic stiffening, which a lot of people think is actually seizure. In his case, it was actually probably just that his brain was responding to not having blood flow, because the heart stopped beating, and then instead of having his typical progression of a seizure with the temporal lobe often having hand fiddling or mouth movements or things like that with a temporal seizure, he went into a more whole body stiffening that I think much more likely arose from the fact that his brain didn't get any blood flow due to the heartbeat stopping during his seizure. There is definitely a syndrome that some people talk about with seizure, bradycardia, or slow heartbeat. Certainly, low blood pressure and passing out can happen in seizures. It's very uncommon, but certainly can hit any age. Again, seems to be more common in boys. And then looking back at heart tracings of patients who had later passed away when they'd been in the EMU, more of the patients who passed away from SUDEP had faster heartbeats during their seizures. They had more seizures that came out of sleep, and then they also had electrical repolarization or sort of heartbeat re-establishing itself problems than the patients who didn't pass away of SUDEP. Certainly, the brain has two major systems that affect heart rate. The autonomic system is both sympathetic and parasympathetic. The sympathetic is sort of the fight or flight response, and then the parasympathetic is its counterbalance to help keep that in check. And you need both of those systems working appropriately for heart rate to stay normal. Looking at how those two systems worked, patients who had SUDEP problems had more problems with how their heart responded to normal autonomic changes, like breathing very deeply or bearing down. Most people think of this as what happens when you try and poop. You actually increase the pressure in your abdomen, and that is something we call a Valsalva maneuver, and that certainly adjusts your autonomic tone. And patients who passed away of SUDEP more likely had problems with that kind of autonomic control. Same issue when we did a tilt table test, bringing people up from lying flat. How quickly did their blood vessels respond to that change in their body position? It's a bigger problem in patients with epilepsy who went on to have SUDEP. This is a problem where patients who have intractable epilepsy are more likely to have difficulty with that autonomic, that fight or flight versus the non-fight or flight systems working together. Unfortunately, in some autopsy series, there have been no changes in the electrical properties of the heart. Some show that the patients who passed away of SUDEP did not have blood vessel abnormalities. They didn't look more likely to have an actual heart attack. So this one paper said that there was not more cardiac pathology in SUDEP patients. Other papers, however, have shown that there were more reversible cardiac changes in patients who had SUDEP, and also some patients with SUDEP had scarring of the heart electrical system, again, probably due to that difficulty with controlling the autonomic and the parasympathetic, the two branches of the autonomic system. So the hyperadrenergic system theory is that there's too much of the fight or flight, too much of the sympathetic drive or the adrenaline system. So if you have a seizure, particularly a generalized convulsive seizure, that can lead to more of the adrenaline, things that cause your heart rate to go up and get the body really going. That can be bad for the heart. That can make it hard for the heart to work. It can also induce the injury or scarring that is called contraction band necrosis. It'll lead to fibrosis or changes in the heart. If that happens, then your heart isn't as good at conducting electricity. If that's gone on chronically, you've done that again and again and again and again, and then you superimpose on that a new adrenal burst with a new seizure, you get this combination of both the heart not working right at baseline because it's gone through this too many times, and now it's being stressed again, and with that double whammy, you end up with a fatal or one that causes death, arrhythmia or heart electrical abnormality. Switching gears to sort of how do families respond and deal and cope, I think one big issue that comes up often is, should an autopsy be done? And I think that autopsies are becoming less and less common in our country and worldwide. I think that is partially because insurance companies don't want to pay for it. I think it's also partly because families don't necessarily feel like they want their loved one's bodies violated. And I certainly can't take away that discomfort. I think that an autopsy can provide answers in many cases that we can't get if we don't do them. And so I certainly encourage my families to try and come to the decision of deciding on an autopsy. It's certainly something that every family has to decide for themselves. Is this right? Is this in accordance with their religious beliefs? Is this something that will provide them closure? I certainly think for many it does, but it's hard to talk about autopsies. I think that to give the diagnosis of proven SUDEP, we have to do an autopsy. I certainly think that autopsies can shed light on risks for other family members, particularly given our increasing knowledge that a lot of epilepsy has genetic underpinnings. And finding out if somebody who passed away with epilepsy, did they have heart problems? Did they have lung problems? Was there something else going on? And I think for some families it does provide closure because it provides some more final answers that we're not able to give while the patient is alive. There is a registry for families who have had loved ones lost to SUDEP to keep track of this. I think that the New York University registry is something that's accepting information from families anywhere. If there is tissue from the patient who passed away, either just DNA, because we certainly understand that there's genetic risks for SUDEP, or if you've had the patient's autopsy and you're willing to donate either portion or the entirety of your loved one's brain, we know that there are brain abnormalities that we need to understand better to get a better handle on SUDEP. And so NYU will take a portion or all of your loved one's brain if you're willing to give that to them. We can mail it to them, and it can be part of the national research on why is this dreadful phenomenon happen. There's a big difficulty of deciding when to talk about SUDEP. I actually think this forum is a really great environment to do it because I think all of you have come here actively looking to learn more about epilepsy. But I think it's hard to say when is the right time to talk about this with patients. I certainly think that some people feel that you should discuss SUDEP as a physician with every patient before you would take them off of medicines, because there is the possibility that their epilepsy will be less well controlled after their epilepsy medications come off, and should they then be aware that SUDEP is a potential risk for that. There is a Scottish neurology consortium that actually feels that everyone should be made aware of SUDEP at the time of diagnosis. And I certainly think that for almost all of the patients that I see when they're initially diagnosed, the families are under such overwhelming emotional stress that hearing your child might die from this could be a very hard thing to hear and might prevent them from hearing anything else that I say about their child being diagnosed with epilepsy. So I almost never bring SUDEP up at the time of diagnosis. I certainly think that the Scottish Neurology Group is actually making the recommendation for adult care, not for pediatric care, and so there are different needs and issues, I think, for adult epilepsy patients versus pediatric epilepsy patients. I certainly think that some patients or some physicians feel it's appropriate to talk about SUDEP if the seizure medicines aren't working. So you're entering the sort of intractable group of patients with epilepsy, and I certainly think those patients are more likely to have SUDEP. They're not the only patients who have SUDEP, unfortunately. But I think once you've had a patient who's come back to see their doctor about their epilepsy enough times that we're getting to the point where the medicines aren't working, by then you have enough of a rapport that you can bring this type of topic up. And some people would say, well, the surgery patients are the ones who are clearly the most refractory, and clearly we have data saying that surgery patients, particularly if the surgery isn't successful, are more likely to pass the SUDEP than others. That's another sort of catchment. But there isn't a right time, and I certainly think this is something that we as physicians probably talk about too infrequently, but it's not an easy thing to know when you should bring it up. If there were more about prevention, I would have spent a lot more time on this. Unfortunately, we don't have great strategies for epilepsy prevention, SUDEP prevention. I certainly think that given the risks associated with not taking medicines and having more breakthrough seizures, we all encourage all of our patients to be compliant with our anti-epileptic therapy regimens, and that's sort of the basis of our treatment. I think that CPR in the 25 cases of SUDEP that happened in epilepsy monitoring units, well, excuse me, there's 25 cases of SUDEP or near SUDEP. 8 of them were near SUDEP, so they had heart and lungs stop functioning. All of them got CPR within 3 minutes. And so CPR within 3 minutes of the heart stop beating did help save all 8 of those patients, in the patients who were in epilepsy centers when they had their event. Of the patients who died of SUDEP, none of them got CPR within 10 minutes. And so I certainly think that CPR up front may be helpful. Unfortunately, we also know from the witnessed SUDEP paper where these were patients who weren't in hospitals, half of them did get CPR immediately, and it wasn't enough to bring them back. I certainly think it's better to know how to do CPR than to not know how to do CPR for anyone, but certainly if you have a loved one with epilepsy. The seizure detection devices are something that I'm very ambivalent about because none of them works 100% of the time, and pretty much all of them go off falsely. So the false positives are going off when patient's not having a seizure. It's something that is just all seizure detection devices do, and most seizure detection devices end up in the back of the closet because families realize that they go ping when they don't need to go ping, and it's not helpful, and it's keeping everybody from sleeping. And then there also is, I think, a false sense of security because they may not go off even if a patient is having a seizure, particularly if this patient doesn't have a seizure but just has a SUDEP event. So I think that the electrical devices are not FDA approved. The U.S. government does not say any of them work because none of them have data to say that they work. And certainly you can buy them. Some of them are manufactured in the U.S. Some of them have approval in other countries in the world. I don't encourage my families to use them because, like I said, they go off at the wrong time frequently and may not go off at the right time. There's a lot of interest in seizure awareness dogs or other companion animals that can sense a seizure coming on. I certainly think that there are certainly good reasons to have companion animals, and it may be that they help with SUDEP. We certainly don't have any scientific evidence to say that that's the case. Some patients get heart electricity checks just to see if there is some underlying heart electricity abnormality. Unfortunately, with most of the heart electricity abnormalities, there's not something we can do that would prevent them from actually having SUDEP. So it's something that does get checked by some physicians for some patients, particularly with regards to some drugs, but I certainly think that it's not a 100% answer. So I wish we knew more about how to keep it from happening. Unfortunately, we don't know enough about why and how it happens to be able to do that yet. I think that there is more information out there. There is a group that's specifically focused just on SUDEP called SUDEP Aware, and then Epilepsy.com is another nonprofit that has set up a sort of SUDEP institute within the Epilepsy.com world that also is focusing on this issue, and so they have information on their website, although it is actually a little bit hard to get to because you have to, if you just Google SUDEP in Epilepsy.com and you go to that link, it doesn't work. But if you go into Epilepsy.com and you type in SUDEP in their search engine, then you get a bunch of links and you can eventually find it, but you have to be a little more committed than if you just go to SUDEP Aware. So that's all that I had planned to talk about, but I do have, I think, about 5 more minutes if people have questions, particularly about the SUDEP issue before we go to the next speaker. Yeah. Yeah, I run the ketogenic diet program on the Dornbecker epilepsy program. So yeah, I take care of kids who have predominantly medically intractable epilepsy, which may be why I've unfortunately had more SUDEP than I would like. Mm-hmm. Right. His risk for SUDEP would be pretty low if he's gotten 10 years seizure-free. That's certainly great. Unfortunately, as with George Washington's stepdaughter and some of my patients, they have been under good control and still passed away with SUDEP. So the risk never goes to 0. For those of you who remember being worried about your children when they were very young, the risk for SUDEP is probably similar to the risk of SIDS, or sudden unexpected infant death syndrome. So it is a very, very rare thing. But unfortunately, unlike SIDS, which the risk goes away as they stop being infants, the risk for SUDEP does not ever go to 0. But I certainly think the fact that your son has been able to be seizure-free for 10 years is great and reduces the risk, but it unfortunately hasn't gone away completely. Oh, sure. So she was wondering about her son who is 35 and has been seizure-free for 10 years and how his risk for SUDEP is.
Not so much a question as a comment. My father and I both have difficult to control epilepsy, and my dad waited to see if my neurologist would tell me, and my neurologist never did, so I was actually really ticked off that my dad was like, oh, by the way, you could die from this. And then when my doctor did bring it up, it was like he was yelling at me for not being able to get seizure control, and so that was really uncool. So that's just something you might want to consider.
Yeah, and I certainly, as I mentioned before, we all try and get patients under good seizure control because that's our job as your epilepsy doctors. I certainly try not to use this as a sort of stick to beat compliance into patients, although I certainly think that it's a part of the conversation, but it's not good to try and make this a cudgel to hit people over the head with. Yeah.
So I was just wondering, for a child with epilepsy who suffers from grand mal seizures, and they're under control, but she also has sleep apnea, is she at a greater risk?
Possibly. I mean, as the study showed, convulsive seizures or whole body shaking seizures certainly are a risk factor, and certainly sleep apnea is another layer of potential problems with their airways. So yes, I certainly think the risk is higher than if she didn't have sleep apnea.
Okay.
I still think that during her childhood years, she's still at much lower risk than she will be potentially later in life.
Even if she's had, childhood onset epilepsy. So she was like 12 when she was diagnosed and now is 19.
Right.
So
I think the risk now is still somewhat low, but she has likely decades of epilepsy,
right,
which will unfortunately leave her with more chance for this.
Okay, thank you.
Oh, you have a microphone.
Oh. My son is 15, and he's had epilepsy since he was a couple of days old. And my question is, he also has a lot of anxiety, so he often complains about his heart racing and other heart-related things, and I'm wondering if somehow that can also wear on his heart in addition to him having seizures.
Quite possibly. I mean, I certainly think if your son has a lot of heart problems, it's probably worth getting a heart doctor to actually look at him and at least doing the heart electricity test. I think that the anxiety is something a lot of our older patients have as a comorbidity or thing that goes along with their epilepsy. And certainly big psychosocial stressors, as I said, have clearly been associated with heart attacks. It may well be associated with a risk for SUDEP as well. We just don't know just because of our numbers. But I certainly think that both the chronic stress and worry of, oh my God, I'm going to have another seizure is not good for you, and then acute worries on top of that can certainly make this problem potentially more likely to happen. Yes.
We're the parents of a child who has non-traditional epilepsy, more like infantile spasms, West syndrome. Is that group any more or less likely to experience this than the more traditional tonic-clonic seizures?
We don't have great data. I certainly think that partly because there's just not as many kids with spasms. I certainly think with spasms in particular, we're finding out more and more why they have their epilepsy, and that puts them into the symptomatic group. And we certainly know patients with symptomatic epilepsy are more likely to pass away than patients who don't. I certainly, with all my patients with infantile spasms, and really all my patients with epilepsy, I always tell the parents, I actually don't ever want to figure out why your kid has this, because if we never figure out why, there's the best chance that they can outgrow it and ideally be cognitively normal, because that's my greatest wish for all of my patients, is to not have any seizures and not need me at all. But I certainly think, unfortunately, with infantile spasms, it's a very, very small portion of those patients who will outgrow it and be cognitively normal. I mean, I think the literature says 10%. I've not been lucky enough to have 10% of my patients with infantile spasms outgrow their seizures and be cognitively normal. So I certainly think that they probably are at increased risk for SUDEP given the severity of the disease, the very high likelihood that there's something underlying it that's part of why they're different. So unfortunately, I think yes, but I don't have any numbers to really back me up on that. One here and then up front.
So I have epilepsy, and I've had chronic anxiety and worry, but is there anything we can really worry about, because it's not something we can really control or prevent, right?
That's part of the problem. I certainly think that encouraging compliance with your anti-epileptic therapy is important. I really actually think that the psychiatric comorbidities that Dr. Kriz is going to talk about later today are a huge issue for epilepsy, and I really encourage my patients who have anxiety along with their epilepsy to try and treat that aggressively, because I certainly think that keeping that under control can really help the quality of life, sometimes even more than my seizure drugs. I think that keeping the depression and anxiety from really being a huge weight around people's necks can actually make more of a qualitative impact than just getting the seizures down. So yeah, I do think that the anxiety needs to be addressed.
Is scar tissue or lesion in the brain symptomatic? Would that be considered symptomatic?
I'm sorry, I missed the first word.
Scar tissue or lesion?
So yes, so I mean, the brain doesn't have true scar, but gliosis, or the brain's equivalent of scar tissue, yes, is something that would make a patient have symptomatic epilepsy due to that structural lesion. Correct. So we have, I think, time for one last question, or I will just cede the table.
I'd like to make a quick comment, Carter. The Epilepsy Foundation Northwest has a new group called SUDEP Northwest to help bring together families who've lost loved ones, families and friends. So if you know of anybody or are interested in learning more about that, that's on our website. Also, the National Epilepsy Foundation, it used to be epilepsyfoundation.org, it's now epilepsy.com, and so they have had some technical difficulties merging their websites over the last couple of months, but hopefully that's all worked out. So.
I just wanted to comment that there are definitely colleges in Portland, and you can find CPR classes available. So for family and friends and loved ones of patients with epilepsy, it's definitely empowering to have the skills for doing CPR.
She just was saying that you can get CPR classes at many places in Portland, at many health centers, as well as colleges and academic institutions offer CPR classes. So if you don't know CPR, certainly you can find one. Yes, it's not specific. It's how to get the heart to beat and try and get air into people's lungs. So general CPR is not specific for epilepsy patients. It's just if they're not breathing and their heart is not beating, then regular CPR is what they need.